Good morning and welcome everyone. Our presenter this morning is Dr. Michael Lynch. Dr. Lynch is the Medical Director at the Pittsburgh Poison Center and also the Medical Director for Substance Use Disorder Services at UPMC's Health Plan, and an Assistant Professor of Emergency Medicine, Toxicology, Pediatrics, and Addiction Medicine in UPMC's Department of Emergency Medicine. DDEP has invited Dr. Michael Lynch to share the value and processes of UPMC's Bridge Clinic telemedicine program for SUD patients in need of urgent but non-emergency medical care. Please feel free to use the chat function during this presentation for any questions that you may have, or you can wait until the end for a direct question and answer session with Dr. Lynch. With that, I turn it over to you, Dr. Lynch.
So I think it's important to back up and understand, what we're discussing here. And, obviously living during the realities of a pandemic that has been waxing and waning and part of our new reality, and understanding the implications it's had on the patients and clients that we serve. Certainly we understand that stress, anxiety, and isolation are all major factors and contributors to worsening substance use or recurrence of use for those either in early or long-term recovery. In addition, because of isolation and physical distancing measures, access to social supports and things like that, and access to care have certainly been limited. And certainly speaking to a group of single county authorities, you live this reality every single day on the front line, much more than I do. So you're much more well aware. But I think understanding that and understanding the various other implications that people with substance use disorders might have to deal with, whether it be using in isolation and risk of overdose, or aspiration events leading to potential for worsening lung injury, housing instability, loss of jobs, revenue, income, et cetera. Those things are only going to be worsened, which doesn't even get into potential for maybe not being able to adhere to distancing, to sanitation, hand sanitizing, mask wearing measures as well, while seeking substances or under the influence and those kinds of things. Variance in drug supply and purity could potentially be an issue as well. So there's a lot of stressors that make this a really dangerous time for individuals with substance use disorders. So looking locally, at least in Allegheny County where I work, some of the data really bears out some of those concerns, which we can see here on the top line indicating naloxone administered by EMS. Overall, that curve has raised above baseline, indicating potential for more overdose events. But at the same time, our ED visits for opioid overdoses, much like for almost any other diagnosis or illness, has gone way down, at least early during the mid-March and April months of the pandemic, as individuals were avoiding going to emergency departments and other care settings. And sort of looking a little bit deeper at that data, we see that those who refuse transport after receiving naloxone, that number has increased significantly. I think it's interesting that at baseline, it's pretty low. Most patients, most individuals who receive naloxone do consent to being transported to an emergency department. But from mid-March and beyond, the number who decline transport has gone up significantly, while those who have been transported has gone down significantly. And I think that just speaks to a concern and a hesitancy to go to an emergency department and place themselves at risk during this time. But that also indicates a loss of a really important access point. We know for a lot of individuals with substance use disorders that an emergency department might be the first and for a period of time only access to medical care, so that all that effort that you all have put into establishing warm handoff programs with local emergency departments can't be utilized if patients aren't showing up there, and if they don't have access to their outpatient providers either. It really creates a scenario where individuals are trapped at home and isolated and potentially not able to access care in the usual ways. So along those lines, we wanted to, we're thinking about how to improve that access to care and how it's affected. In-person treatment access is certainly limited. We know that some of our outpatient addiction providers locally moved to, in April, 90% or so of their visits were through telehealth as opposed to in-person, both in an attempt to protect patients, but also protect healthcare providers and their staff. Telehealth options, I think, are really important and really open up a lot of possibilities to increasing and enhancing care and access to care to populations that may not have otherwise had it. But it has important limitations. There's a reason that we prefer to see people in person, and there's data to be gained and care to be provided that probably requires an in-person touch. But when that isn't a good option or an available option, telehealth does offer a good alternative. Harm reduction strategies and programs have really had to be innovative, which as a community, that is a community that has gotten used to being innovative and thinking outside the box and adapting to their environment. So whether it be through mail or vans and delivering care and naloxone and fentanyl test strips or other resources to people with use disorders, they've had to adapt to this new reality as well. So thinking of telehealth as a solution, it's not a new concept. It's something that we've been thinking about and evaluating for some time. There is data to support it. So we have seen in these two studies in Maryland and West Virginia, patients who were maintained via telemedicine on buprenorphine versus those who were engaged in in-person treatment had really similar 3-month engagement rates, almost no difference. In fact, statistically no difference. And at the same time had a similar rate of negative urine drug screens. So it indicates, and more data would need to be gathered than these two relatively small studies, but it really indicates an ability to deliver care in this way that can be effective, particularly if the alternative is not having access to that in-person care. So it is a real alternative and a real option that I think is going to be important moving forward for a lot of our patients. So any discussion of telehealth, particularly around controlled substance prescribing, we need to consider the Ryan-Haight Act of 2008, which requires an initial in-person visit or assessment before any controlled substance can be prescribed. And that is still the case. There are exceptions that apply to delivery of SUD care that pre-existed any current waivers, and we'll talk more about regulatory waivers in a bit that sort of have waived the requirements of Ryan-Haight temporarily during this public health emergency. But existing exceptions, even prior to COVID, have been that a patient can be in a DEA registered facility or in the presence of a DEA registered provider and still be able to do a telehealth consult and prescribe buprenorphine or other controlled substances without necessarily having to perform that in-person visit. So the telehealth provider certainly has to be licensed to practice and prescribe in the state where the patient's being seen. It has to be part of their usual clinical practice. They can't sort of just have a side gig doing that. But within that, it allows opportunities both in primary care, I think in addiction treatment provider settings where the physician provider may not be on site, in hospitals and emergency departments, to deliver care to patients who either are in a DEA registered facility or in the presence of a DEA registered provider to deliver a medication treatment in this way through telehealth, which I think opens a lot of opportunities that haven't really been fully realized at this point, or we're really just scratching the surface to expand the accessibility of this kind of care to patients, particularly in settings and communities where an in-person provider may not be readily available. More recently, in 2018, the Support Act actually allowed for a provision that would create a special registration for healthcare providers to prescribe controlled substances via telemedicine in legitimate emergency situations. That was passed, I believe, in October of 2018. Required that to be done within a year. As of now, it still hasn't occurred. But I think that is a lever that we have to continue to push to potentially make this available in appropriate situations, again, where alternatives aren't available, as a potential sustainable solution for emergency access to medication care when needed. So again, some of the ways that we've looked at and have already sort of established these types of programs, in DEA registered OUD treatment facilities or offices. So if a program or facility, the facility itself is registered and a patient is there with, say, nursing and support staff, but the provider isn't on site, as long as the facility is registered, the provider can legally provide telehealth services and e-prescribing of medication, including buprenorphine. Primary care, we've looked at this in some places where we would do telehealth consults, where we would see a patient directly in a primary care office and lead to e-prescribing from there, so that the primary care doctor wouldn't have to manage that part if they weren't comfortable with it. And then in hospitals, emergency departments, urgent cares, and I think, again, it allows for some capacity to deliver care. So what are some of the temporary regulatory waivers? And this has to do with the announced public health emergency related to COVID-19. So we have federal and the governor had declared a statewide public health emergency as well. The federal level, it allows now for initiation of controlled substances or provision without an initial in-person evaluation using telemedicine. In fact, specifically for buprenorphine, it allows telephone-only evaluation, meaning if the patient does not have access to video because of technology issues, broadband issues, things like that, they can do it through telephone. However, we cannot do benzodiazepines. That is not included in the telephone-only waiver. And it also allows interstate practice with a DEA license. There are other waivers as well, but those are some of the ones I wanted to highlight. At the state level, working with DDAP, DHS, and DOH, a number of provisions, essentially understanding the lack of in-person access to patients and really trying to support improved accessibility for patients to services through telehealth, understanding that the signed consents and things like that require in-person signatures may be more difficult to obtain in emergency situations, extensions of take-home doses from OTPs, et cetera. So there have been a number of responses that I think have created an interesting time that allows us to evaluate and assess our programs that we've developed in response to evaluate and analyze whether they're safe and how effective they are, hopefully so that when we're on the other end, we can take a look and see where it might make sense to push for longer term changes in regulation versus other things that probably were only appropriate for a time of pandemic. And I think those questions have yet to be answered. So getting to some of the programs we've developed, and primarily the only one I'm really going to focus on today is a telemedicine bridge clinic. We have expanded our telemedicine consultation in our emergency departments. So in most of our UPMC EDs, and with some still just waiting on final credentialing, providing telemedicine consultation for buprenorphine as well as benzodiazepines if needed. Though a lot of our primary ED docs will do that anyways without the consultation, but to make sure that patients can leave with prescriptions, particularly at this time where access to follow-up care could be a bit delayed. The Poison Center, with support from DDAP, as well as County Health Department here in Allegheny County, developed some programs and processes to assist providers in initiating buprenorphine or managing other types of withdrawal, including alcohol, benzodiazepine, in addition to managing acute toxicity, providing information and recommendations about induction. We'll follow up with patients, 1 in 7 days, refer them to the Get Help line to enhance access to treatment, in addition to whatever the local warm handoff process is, which is still our first line, is to make sure that patients get entered into that process. But the most, I think, relevant here to our discussion is the telemedicine bridge clinic. And this was born out of discussion with a number of stakeholders, including and especially Department of Drug and Alcohol programs. And initially, I think what prompted the discussion, this was all in mid-March, was the upcoming closure of liquor stores and state stores, and a prediction that we would be seeing more patients suffering from withdrawal at the same time that patients were going to be less likely to go to an emergency department, and we were less likely really to want them to go at that time because we weren't sure what was going to happen, what risk they could be exposed to. And so the idea of it was to understand that much of the care, initial medical care, can be provided as an outpatient for almost any substance withdrawal syndrome, whether it be alcohol, benzo, or opioid. We understand that in certain cases, patients just need to be in person in a physical health facility, like an emergency department. Patients with, active delirium tremens or really severe withdrawal, even if they don't need to be admitted, they need to be initially stabilized. It's absolutely the case. But we also know there's a large number of patients who can be managed and have their symptoms managed outside of a hospital, but accessing or getting them to be seen in a really timely fashion, like within a day, is very difficult in the best of circumstances, let alone in the midst of a pandemic. So the idea was we wanted to create an extended hour telehealth clinic that would allow an initial evaluation of a patient to provide medical therapy. So whether it be benzodiazepines for withdrawal from alcohol or other GABA agonists, or buprenorphine prescribing or non-opioid prescribing if indicated for patients with opioid withdrawal, or even initiation if a patient was transitioning off of long-term opioid use, allowing an evaluation by myself or one of my colleagues. There's 5 of us, 4 of us are board certified in addiction medicine. The 5th is qualified and taking his exam this year. We're all board certified emergency and toxicology providers. So allowing us to evaluate a patient and make an assessment about the indications for initiation of medication, which can include sort of home induction of buprenorphine in addition to withdrawal management, benzodiazepine therapy, and so forth, while local care is being established. So my thought and my sort of goal coming into this was not to try to, replace existing treatment programs, where they are, provide necessarily longitudinal care, because I do think that over time there is an absolute need for a local in-person support presence, in addition to the case management, behavioral health needs that I can't coordinate remotely. So the idea was that whether through a single county authority or case manager and management services at a substance use provider agency, that they would help to coordinate the care of the individual. And if it seemed that medication therapy may be necessary, but they could not get that patient sort of immediately seen, that we would be able to provide an outlet that could allow for that, so that we didn't lose patients in withdrawal who return to use. As we know, it's a particularly risky time in the transition to recovery, is that immediate phase. So that was the goal behind it, behind the clinic, was to provide that niche service to individuals throughout Pennsylvania. And so the way that we wanted it to work, it's a fairly easy concept, but what I found as I was working with my department and at UPMC was getting a patient initially engaged is a bit more complex. I can do a video or phone consult with a patient in about 2 minutes through VidYO or Doximity or any other number of HIPAA compliant access platforms. The problem is both to make sure we were providing good care, legitimate care, traceable care, complying with all regulations. We needed the patients to be registered and scheduled and create a medical document, a health record of the visits and our thought process, like we would with anything else. And that's very easy when it's follow-up. But if it's a new patient, particularly one who hasn't been to UPMC, that can be a bit more challenging than it seems like it should be on its surface. And the other thing is I needed that access to health records to be able to legitimately e-prescribe medications to local pharmacies, et cetera. So we worked with our scheduling department here to develop a process for that. And the way that I envisioned it essentially is that the patient, probably in conjunction with somebody from a single county authority office or case manager from a provider agency, somebody who could help the patient and facilitate that connection, would call into this number, the 412-432-1042 number. That's our central scheduling. And we sort of explained who we were and what we were doing to them and worked with them such that they know if you call in saying, oh, we're looking for the toxicology bridge clinic, they know what that means. They can schedule either a video or phone only visit depending on the capabilities of the patient and their technology. And what they'll do is they will provide instructions to create a My UPMC account. And that part is online. It's fairly straightforward. It takes a few minutes. It's a fairly standard registration to a site kind of process. And it doesn't cost anything. It doesn't carry with it any obligations or anything like that. But through that is the way that we're able to schedule telehealth visits. That's just the way our telehealth platforms are built at this time. And so that's why, while I'd love it to be a lot more streamlined and these couple steps create a clunkiness that I don't love, it's necessary to fit into the process of having a legal registered visit with an EHR documentation. So once they do that, and at the time while they're on the phone, an appointment will be scheduled. We understand this is urgent. That's the idea. So it'll be scheduled for the same day or the following business day. I initially wanted to offer weekend services, but what we found is that the scheduling capability and capacity wasn't there during the weekend. So for Monday through Friday, the scheduling site, the scheduling center is open from 7 a.m. to 7 p.m. So you can call at any time during then, but to allow sort of some delays in scheduling from the time of initial call, the hours of our service are from 8 a.m. to 8 p.m. So for 60 hours a week, individuals can be scheduled. And the other step, and this isn't absolutely necessary, but what I find is that in the process of facilitating medical care and things like that, oftentimes you may want to speak to the physician provider just to give some background or say, this is our plan. Patient's going to be getting into X, Y, or Z program in 4 days. So if you can help us to get him or her to that point, that kind of conversation can be facilitated through our med call, which is 647-7000. That'll connect you directly through an operator to the toxicologist that would actually be seeing the patient. It also serves as a notification for us, so we know that somebody will be showing up on our schedule. Then we'll see the patient, do an assessment, evaluate the patient clinically, and based upon their history and what we're able to assess via the telemedicine visit, come up with a plan of care, which would include in appropriate situations medications, such as benzodiazepines, buprenorphine for management of an immediate situation, or induction of treatment in patients who are high risk for developing a withdrawal syndrome. And then, the patient will be given aftercare instructions and so forth, with the understanding that the facilitating SCA or case manager will continue to help that patient access local care and all the other social behavioral resources that we know that many of these patients are going to need. Being perfectly honest, we aren't providing those services at this time anyway. We're only providing the medical care. As I said before, patients without access to live video capabilities can be evaluated by phone only, but we cannot prescribe benzodiazepines following phone-only evaluations based on current regulatory waivers. We can prescribe buprenorphine in that way. We documented in EPIC provide aftercare instructions, which actually the patient will access through the My UPMC account, which can allow some further interaction and resources for the patient. When the patient is registering, the demographic information and payer information will be gathered at that time, and we'll submit a bill through our central sort of revenue cycle here, just like we would if they had shown up to an emergency department, for instance. And you know what, we understand that as with any billing process, not all will probably be reimbursed and so forth, but that I've discussed it a few times with our emergency department, which is where the billing would be coming from, and they felt comfortable that regardless of the population and understanding that there would be non-contracted payers, that as an emergency service without alternative, the patients would be protected from surprise bills, which is something I made very clear to our folks, and that the recuperation would be sufficient. So I quite frankly, I'm not as worried about that, but I know that that has been the common and understandable question. And then follow-up visits, should they be necessary, can be scheduled in the same manner. So we've had this happen already. If a patient has difficulty accessing sort of subsequent care and there's really no other alternative, and they need to follow up with somebody for ongoing management through the same process, the same scheduling process, which should be easier second time around because the My UPMC account will be there. A follow-up appointment can be made with us. So I'm going to give a couple sample cases and then stop there to allow for some discussion. So the first case we had, and I'll keep a lot of this fairly vague, was a patient with alcohol use disorder who had a history of significant alcohol use. He had had periods of long-term recovery, but also extended periods of use, history of some complicated withdrawal, including a seizure in the past, but for a variety of reasons, could not or did not feel comfortable going to an emergency department or healthcare facility. At the same time, because of that history, he could not identify a local physical health provider. He had access to a psychologist. He had the local SCA was providing, just regular and very intensive support, doing everything they could. But the one piece that was missing was the medical management. And so honestly, what he was doing was he was continuing to drink because he was afraid to stop. He wanted to, but was afraid to stop because of the potential for withdrawal. So we were able to see him. We managed him using Librium, which he tolerated very well, completed 5 days on that, never had any significant withdrawal, tolerated that well. And we actually initiated long-term management for him because we knew that he would not have available medical treatment. After long discussion, including understanding the patient's preference, which was for disulfiram in this case, I ended up prescribing that for him. And because he had difficulty still following up with a physical health provider who was able to provide those services, though he had all the behavioral health needs he needed, I ended up actually seeing him a month later in order to renew his disulfiram because he felt really comfortable and confident and felt he was doing very well on that. And so, just in our discussion with him, he was very appreciative and very open and comfortable with that way of delivering care. I think we all would agree it may not be ideal, but in his case, there just was not another option. It worked out well. Another case, and this one was a little bit convoluted, but it was a case of a patient who was in an inpatient setting and had been managed with tapering buprenorphine. And the plan had been to follow up with a provider whose plan was to maintain the patient on buprenorphine, but there was going to be a gap from discharge to follow-up that wasn't able to be filled necessarily. And it was going to be from a Friday to a Tuesday. So there wasn't really an alternative option for moving up an appointment. And so we made an appointment with the individual to be able to provide that bridging prescription. As it turned out, I think upon hearing about that, the agency or the discharging provider ended up writing the prescription themselves, whereas originally they hadn't been planning to. So our visits ended up not being necessary, but that was an option that we were able to offer to help that patient who was really nervous about leaving, sort of having completed a buprenorphine taper and planning to start maintenance therapy as part of his plan for long-term recovery, but going to have that gap at home without it. So I think that's another example of a way that this kind of service can be helpful to patients. But beyond that, honestly, I think because of, for a lot of reasons, the service hasn't been accessed regularly. I'm hopeful, if it's not necessary or ends up not being necessary because people are able to find and get their patients into medical therapy treatment when it's indicated very quickly, then quite frankly, great. That would be ideal. But from my personal experience, I suspect that isn't always the case, and that there is at least a subset of patients that we all share and take care of who could potentially benefit from a short-term medical engagement pending establishment with a longer-term care provider. And that's really where we're hoping to fill in. Long-term, I think it would be fantastic if this becomes something that is sustainable from a regulatory standpoint, that we could have shared, with providers potentially throughout the state, and have some centralized, more readily available, potentially even 24/7 support accesses. But those are the things that are sort of more down the road. And I will also be very open and honest about the fact that what I just described is really dependent upon current regulatory waivers. We could not provide this service in the environment of pre-COVID regulation because of that requirement for an initial in-person visit. So the duration of this at this point, I think, is a big unknown and a big question mark, particularly as we hear, for political reasons, the federal emergency may or may not be continued, beyond its expiration, I think next month or this coming month. But I'm hopeful that won't be the case, particularly as we see it surging in so much of the country. But there are a lot of unknowns. But in the meantime, as long as we're able, we'll be here and available to provide that service. So I know I just talked for a long time, and I'm sure that there are questions that I'll be happy to try to answer.
Hi, I have a question. This kind of looks like it's geared towards the SCAs and the case management departments. Is there any SCA follow-up after these calls?
Meaning, do we follow up with the SCA?
Make those referrals for treatment if they're just starting on a Suboxone program?
So our plan, our hope had been that the patient would already have been engaged with somebody who's facilitating that referral locally, because say if somebody's in, I don't know what in most counties, quite frankly, we won't have a specific place to refer them, and are planning to leave really that to the experts, the SCAs or case managers to continue. What we're hoping to know is what the gap in need is, which is why I think some of that initial discussion with the person by the case manager or SCA would be very helpful, so that we can coordinate care. The degree to which we're able to share sort of the medical evaluation and exam is somewhat limited, as you know, just based upon even just standard HIPAA compliance. But I think with patient permission and so forth, we would be happy to engage back with whomever to discuss what the plan, what our recommended plan of action had been medically. I think it would depend on the case and the person who's referring the patient, and particularly some of that preliminary discussion to help us understand what the need is that we're trying to fill, because we understand it's going to be very different for different patients, and if for whatever reason the plan is a taper or a true quote unquote detox if a patient's plan is for long-term naltrexone or things like that. That would be helpful to know, and we can make recommendations based on our visit. But we're happy to follow up. It's not a regular part of it, just because it will depend upon patient permission during our evaluation to share the information externally, and the desires of the person who referred the patient. I don't know if that answers your question.
Yes, thank you.
Sure.
Hi, good morning. I have a question.
Please.
So UPMC is a large organization, and you're very lucky to have all the resources that you have. What do you recommend to smaller counties who have smaller hospital systems and not as many resources at the individual hospitals? How could we set up something like this?
Well, yeah, I mean, the probably the biggest resource in all of this was the availability of the human resource. And our group is a little bit unique in that we don't have regular sort of office kinds of hours, so we're not leaving gaps in a schedule. We are hospital based, so we can be a little bit more fluid in our flexibility of scheduling patients. And then beyond that was the scheduling and so forth. But to do a telehealth evaluation, I think first of all, I know we're not the only ones doing it. But you are right in that I think it is mostly larger organizations. I know Lehigh Valley is, and I know Penn is in Philadelphia. But I think if it's going to be through telehealth, the first thing that the smaller hospitals and facilities would have to do is just to make sure that they have access to a telehealth platform that allows for engagement. Now, quite frankly, it's not that hard. You can download an app on your phone individually, Doximity being one that I have, for instance, that was free to me. And so a provider can do that. But then the next hard part, I think, was really the registration part, which was odd. So if a patient isn't already part of in that system. So if the patient has already been seen there, that part should be easier. They would just have to have an ability to activate a new visit and an associated code along with it to be able to document and send prescriptions, et cetera. But I think in some places, they are sort of doing it in a less structured way, where especially even by phone, as sort of a low barrier access, where they'll take a phone or do a Doximity type evaluation and submit a prescription and then create a chart sort of after the fact or some other kind of documentation. So if the goal is for telehealth, I think there are a number of ways of doing it. I think most hospitals have or are in the process of coming up with telehealth solutions for a variety of services. So then it's just a matter of identifying individuals who provide addiction care who would feel comfortable doing that and working with their institution to sort of access whatever strategy they're coming up with. Because I do think that in the setting of COVID, most hospitals are trying to come up with telehealth solutions. So I am fully supportive of any hospital or provider group being able to come up with this, particularly if it can maintain local care. I still think local care is more ideal whenever it's available.
So are most of the resources coming through the emergency department or not?
Yeah, so I mean, I worked with our emergency department administrator to connect the dots on the scheduling and our Epic team to create sort of this visit type. So that was where we went, and our billing comes through the emergency department. Now that is because that's where I live. That's where my group is. So I think, most emergency departments wouldn't have the providers who would feel comfortable doing this. If they did, then absolutely they could. Otherwise, it would probably be through an addiction group, whoever provides the service, whether internal medicine, emergency medicine, toxicology, psychiatry. Those groups could all do it. So there weren't a lot of dollar resources put into it. It was just some time to connect the dots. That was why it took us more than a month to connect all the dots, but primarily around that registration piece, which is why I focus so much on it.
Thank you.
Yeah, and I'm sorry if that doesn't fully answer your question. I do think it's possible kind of anywhere if people are willing to put the time in and prioritize it. I don't think that the resources necessary are so unique to a place like UPMC.
Yeah, that was helpful. Thank you.
I have another question too. In relation to the prescriptions, are they like a certain amount of time? I mean, are you prescribing like a month, or is it just a week, or is it dependent upon the substance?
Definitely dependent upon the substance and the plan. So like if it is alcohol, if we're treating alcohol withdrawal, for instance, which as we know is still sort of the substance in the withdrawal state that typically we're seeing the most of and often requires the most urgent medical therapy. We're typically managing with benzodiazepines for 4 or 5 days. And then my ideal, and it really depends again on what the patient's plan and what the coordinated plan is going to be. If the plan is then to enter a residential program, then I would probably just do that to help them through that detox period that a lot of those residential programs need. If the plan is to continue with ongoing outpatient medication therapy, maybe through primary care or something like that, but there's going to be some delay, then I'll discuss with the patient initiation, based on their medical history and needs of things like oral naltrexone or acamprosate, or in the case of one of our patients, disulfiram, which I use sort of as a third line behind those alternative agents. And if I prescribe something like that, again, depending on what my understanding of the plan for follow-up is, I would prescribe something like that for a month. Something like buprenorphine, whereas my preference in general, based upon existing medical evidence, is that patients would be initiated and maintained for some period of time on that therapy or transition to an alternative medication treatment. Typically I'm not going to prescribe based on one visit for more than a week. If that, my preference would be that in that time frame there would be some degree of local engagement, somebody who could either continue that therapy, transition to a methadone program, or initiate a taper down in preparation for intramuscular naltrexone, or if it's going to be abstinence-based therapy, some sort of taper. And again, we can manage that if that's going to be the approach. And if in that week's time that still isn't available and ongoing treatment is needed, then we can have a follow-up appointment. But especially with initiation of something like that, I don't feel comfortable prescribing for more than a week at the outset without having the patient reevaluated medically before ongoing prescribing. And then for anything else, it just depends on the patient. I mean, we can provide, if they have a wound or a cellulitis or something like that, or we can provide some antibiotics and, those kinds of things as well if needed. So yeah, it's patient dependent, but that's generally our approach.
Okay, perfect. Thank you.
And I see one in the chat box. Have you worked with your UPMC affiliates to present these options? Some of the SDA limitation is the local provider's willingness to support this service. And by local providers, do you mean like outpatient providers, or so those who would see the patients subsequently? When I hear UPMC affiliates, I often, and part of it is my background, I'm sort of acute care based, so I think of hospitals and so forth who wouldn't necessarily be involved with this, or if they are, they'd be using our telemedicine prescribing process. But as far as outpatient or primary care, if that's what you mean, so UPMC affiliated outpatient providers, we honestly, no, we could. I didn't anticipate that they would be the ones primarily responding to us. David and others are, I think, making this program more on the radar of our outpatient providers, just so they're aware of what we are and what we're doing. So through their own case management coordination, they can refer to us if needed, or potentially see patients after our care. But that can be more of a priority for us, if that's what you mean with your question. I just want to make sure I'm answering it.
Dr. Lynch, this is David. So I can add on to what you just said. That's the SCA from Blair Judy, and she can respond to your question. But I also wanted to piggyback on what you just said, is that the managed care companies really could sit down with the SCAs and really figure out what providers, help the providers to be more receptive to the handoff. So this is a stabilization program that Dr. Lynch is providing. It will be essential and valuable to the individuals, but after maybe 3 to 4 days, when we're past weekends, holidays, the individual is more willing to come in, or we've identified a service, I think that's where we can really sit down and figure out what agencies could take this handoff. It's probably more of just education to the providers that good care has been provided by this telehealth bridge clinic. The person is stable, but as Dr. Lynch mentioned, ongoing care is now needed. But for all the SCAs, I really encourage you to reach out to the managed care companies, the behavioral health, and let's figure out a plan for where these individuals can go, or the physical health side as well, if the individual wants to keep their care on the medical side.
And I should have put it up here, and Jonathan or anyone else, if you don't have it, certainly we can send out my email. So if there are follow-up questions or concerns, or you try to do it but it doesn't work for you, or any of those kinds of things, I'm happy to respond as best I can.
Yes, we can make sure that everyone does have access to your email. They can also contact DDAP, of course, with any questions, and we can pass those along.
We still have 10 minutes. I'm happy to take more questions.
Dr. Lynch?
Yes.
Would you be interested, I'd like my case managers to hear about this. Would you be interested in presenting this again for staff of the SCAs this time, so that they can understand this? Also, possibly the directors of our outpatient clinics also.
Yeah, absolutely. I'm happy to present and discuss and get feedback, quite frankly, from anyone who would potentially be accessing it or using this program. And honestly, because it is new and different and things like that, and we sort of set it up, I'm always happy to receive feedback about what works and what doesn't work, and where my blind spots may have been in developing it. Because the one thing I'm certain of is that there were some and are some. So it would definitely be a growing process. So I would absolutely be happy to present it, answer all the questions I can, and hear feedback from you and any group that would benefit, or from whom I would benefit.
All right. Were there any other questions from the group? I was going to say, if not, I think this kind of concludes our presentation. Thank you, everyone, for joining us this morning. Again, if you do have any questions, feel free to email DDAP, and we will be able to pass those questions along to Dr. Lynch. And Dr. Lynch, thank you for taking time this morning to present this to us. It is appreciated.
Absolutely. Thank you for having me. And thank you all for participating. I really appreciate it. I know you have a million things going on, a million things to do. So I very much appreciate your time.
All right. And with that, I think that concludes this presentation. Thank you, everyone.
Thank you.
Thank you.
Thank you.
Thank you.